Thank you all for showing up, and thank you, as Chris said, to all of our sponsors for this evening. We are going to speak this evening about what is on the horizon. That's a big topic, and obviously I'm probably not going to be able to hit on everything, but I picked some areas that are hot topics in research, and even a couple that are a little odd and out of the box in terms of where MS might go. If you can, try to hold your questions until the end, and then we'll have plenty of time for Q&A. So what are some of the needs that we would like to address going forward with MS? Well, obviously, we would like to cure MS. But when we say cure multiple sclerosis, if we went around the room, that might mean different things to different people. It might mean that we would like to be able to diagnose MS much more accurately, much more quickly, so that we can treat it at that point. What if we could prevent it altogether? What if there was a world free of MS because we never saw people diagnosed with MS in the first place? What about better treatment options for symptoms? If we had a therapy right now that stopped MS dead in its tracks for everyone, that might still leave people with some existing disability and symptoms to be managed. We would love to have ways of stopping MS in its track and also of reversing the damage that's been done. We're going to hit on some of these topics this evening. Before we go into that, though, I'd like to take a step back and say, well, how do we get to a new treatment for multiple sclerosis? What goes on behind the scenes, and how are new drugs developed? One of the concepts, and you may be familiar with these terms, but you'll read about research sometimes, and they may use the term in vitro or in vivo. If they say something is in vitro, they mean it's in a test tube. And sometimes new discoveries do come from something that's discovered in the laboratory, and these can be important lines of research. But if you hear about something in the test tube, you'd like to say, well, okay, well, now what? Well, then usually the next now what is in vivo, and in the laboratory that may mean an animal model. In multiple sclerosis, that animal model is called EAE, experimental allergic encephalomyelitis. This is an artificial version of the MS that we see in mice. And so there are a lot of breakthroughs that you'll see at the mouse model for EAE, and these are exciting, but again, you'd like to see it take that next step forward into humans. The mouse immune system, at the end of the day, is not a human immune system. There are a lot of similarities, but there are some differences. And there have been examples of things that have worked very well in that mouse EAE model that have not worked in humans. And so when we see these laboratory studies, whether it's in the test tube or in the laboratory animal, we want to take it that next step forward. So there are 4 phases of research that we talk about, whether it's for hypertension or multiple sclerosis. Phase 0 means we're just looking at what the drug does in a human. How is it absorbed? How is it metabolized? How long does it stick around? These things are called pharmacokinetics and pharmacodynamics. So these are going to be done typically, this phase 0 research is going to be done in a healthy volunteer. So they are going to take a bunch of 18 to 24-year-old, typically males, and they're going to pay them a little bit of money, and they're going to say, we're going to give you drug X, and we're going to do blood samples, and we're going to do urine samples, and we're going to see how this drug is metabolized. We're probably going to do some blood work to look at your liver function studies and see how this drug is broken down. So at phase 0, you're not asking, does the drug work at all? You're just asking, how does the human body metabolize it? From there, we go to phase 1. These studies may be done again in healthy volunteers. This could be just a bunch of guys that you're paying money to start looking at the safety. Or it could be done in someone, for instance, with cancer patients. What if you had someone with a very aggressive terminal cancer? That individual might be willing to sign up for a phase 1 study where very little is actually known about the treatment, but they're willing to try it out, mainly to get safety data, but obviously for that individual, they're hoping it has some effect. So phase 1 is, again, mainly just looking at the safety of the medication. From there, we go to phase 2. In phase 2, now you're going to start looking at people who actually have the health condition that you're looking at. So in MS, these are going to be individuals with multiple sclerosis, and they break phase 2 down into 2 different types. There's 2A and 2B. 2A is mainly looking at the dosing and the safety of the drug. 2B studies are more looking at the efficacy or effectiveness of the drug. These are usually small studies. They're done at a single site. There's a lot of blood work involved with these sort of studies. There may or may not be a placebo group. With the phase 2Bs, there might be. With the 2As, usually there's not. So again, just trying to hone down, the safety and effectiveness of the drug. When it really gets interesting is when you get to phase 3. There are lots of examples of drugs who never make it past a certain phase. I remember a few years back, there was a phase 1 study of what we call a monoclonal antibody that was being looked at. It wasn't in multiple sclerosis, but in the animal models, it had looked good. When they got to these healthy young men and tried it out for safety, some of these guys actually died from this test drug. So obviously that one didn't get to phase 2. There are things out there that recently in the MS world we'll talk about a treatment that failed in phase 2 treatment, so it never got to phase 3. Phase 3 is going to be a large, multi-site, frequently international trial. So they're going to go to multiple different sites around the globe. This is a large placebo-controlled or maybe an active comparator-controlled trial. One of the challenges in multiple sclerosis is scientifically, you'd like to do a placebo-controlled trial. You'd like to say, I'm going to compare my drug to a sham treatment. Well, if you have relapsing remitting MS, we have now 14 FDA-approved treatments for relapsing forms of MS. How do you ethically go to a person with relapsing remitting MS and say, I'm going to put you in a study where there's a 50-50 shot that you may end up on nothing, and you may be on nothing for 2 years or more? So now what the FDA usually requires in relapsing remitting MS trials is called an active comparator. So you're going to take your test drug and you're going to compare it to something that's already out there FDA approved and show that your drug is as effective or more effective than that known treatment. In relapsing remitting MS, these trials are usually 2 years. Once the trial is done, it goes into what we call an open label. That means the people who were in one of these groups, we're going to tell them which group you were in, and they're usually given the option then to roll over into the test drug until we get the final data and hopefully is submitted to the FDA. Phase 4 studies are trials that are done after the drug is already FDA approved. So the drug is out there, and maybe there's a question about maybe an alternative dosing schedule or looking at extra safety with the drug, or maybe they want individuals on the medication to give feedback about what their perception of the drug is. So they're having them doing diaries of what they think. So phase 4 is, again, that last study. So at the end of the day, research is about time and money. And the average length of time for a new drug to go from concept to FDA approval is 11 to 14 years. The average cost is $86.5 million, and only 8% of these drugs actually will make it to being FDA approved. 92% will fail. So there is a lot of cost in research and development, and I'm not here to defend the high cost of medications. These companies are ultimately in it to make money, and so they will recoup that research and development cost. That's sometimes why some of these very labor-intensive drugs will have a high price tag when they get FDA approval. So one of the things that has maybe sped this process up, and this technology was actually funded through the National MS Society, is something called micropillar arrays. And this was developed through the University of California, San Francisco with assistance from the National MS Society. That little volcano-looking thing there is actually microscopically sized. It is, you could not see that with the human eye. It's a fraction of the size of a grain of sand. Can anyone take a guess at what that green blob is growing on that little micropillar? Any guesses? Myelin. That's essentially right. That is an oligodendrocyte that makes myelin. So that is a single cell that makes myelin. And so what researchers can now do with these micropillars is they can put these little microscopic, if you will, tubes with oligodendrocytes growing on them in a test tube, and they can test thousands of chemicals to see if they actually help promote myelin repair. So this is being done as part of the neural repair research to search for compounds that would actually help repair damage in the brain or spinal cord. And an example of where this helped out quite a bit was this year when the study was reported on clemastine in multiple sclerosis. Clemastine was a direct result of this micropillar technology. What the University of California, San Francisco did is took lots of common medications. Clemastine is the active ingredient in Tavist. It's a decongestant. It's been around forever. And what they found is in this micropillar array that clemastine made those oligodendrocytes happier, and it helped them grow myelin. So they were able to maybe shave years and years off of the research process. No one ever thought of clemastine really as a neural repair molecule, but they got a hit on it with this technology. They took it then directly to human testing in a phase 2 study of 50 people with multiple sclerosis and optic neuritis. They showed that the people treated with the clemastine had improvement in their nerve conduction as measured by something called visual evoked potentials. Visual evoked potentials, if you may have, some of you in the room may have had this. They put you in front of a little TV screen. We have electrodes hooked up to your head. TV screen has really bad channels. All it plays is a checkerboard pattern that flashes back and forth. But with that test, we can measure how long it takes the electrical signal to get from the back of your eye, the retina, through the optic nerve to the visual cortex in the back of our brain. And what they showed in the clemastine treated group, that electrical conduction had improved. We were actually repairing some of the damage. There was a trend towards improved visual function. That's important because it's really great if we can make an electrical test look better, but at the end of the day, what really matters is that we make the person better. So this is this research will move on. Hopefully they'll be moving into phase 3 testing, and this would be a potential neural repair molecule. Lots and lots of work going on in genetics, and we understand more about the genetics of multiple sclerosis. We certainly don't have all of the answers yet. There is a large international MS genetics consortium, researchers from around the globe sharing information on the genes that code for multiple sclerosis. And to date, they've identified at least 159 genetic variants that play a role in your risk for multiple sclerosis. There's been quite a bit of interest in multiple sclerosis in African Americans. Traditionally, we've thought of MS as being less common in African Americans, and usually that was true. For the first time last year, one of the California MS centers reported in their newly diagnosed individuals more African American women than any other group of people diagnosed in their clinic. So something about the prevalence and the who gets MS may be changing a little bit. To date, we've identified 8 genetic variants of multiple sclerosis that are specific to African Americans. So what's going to come of this genetic research? We don't know, but some of the questions that we would like to see answered is, how do these genetic variations affect immune function? What is it that they're driving? We know some of these genes play a role in T cell function. Some play a role in vitamin D metabolism. Could we, with these genetic discoveries, actually take a step closer towards customized therapies for multiple sclerosis? Every time we get a new treatment available to us, that's wonderful news. But on the other hand, it also presents a little bit of a challenge in that our toolbox for managing MS is getting bigger. How do we know that we're picking the best therapy for the individual from day one? And the simple answer is right now we don't. There is a little bit of guesswork. Frequently, we get it right on the first try. Some of you in this room are probably examples of people who've maybe gone through multiple medications for your MS before you find something that you can tolerate and that seems to fit your MS. What if through pharmacogenetics, through looking at your individual genetic profile, we could customize your treatment from day one for your MS? That would certainly be a step in the right direction. We know that MS is partly genetic, but it's also partly environmental. How do these genetic factors interact with the environment? Most things in the environment that we think of as MS risk factors are not exotic, weird things. They're things that most of us have been exposed to. Common viruses, things like low vitamin D levels, low vitamin D is present probably in 40% of the general population. It's present in 85% of people with MS. But obviously, vitamin D deficiency by itself is not enough to cause MS. Smoking is a risk factor for multiple sclerosis. Not all smokers get multiple sclerosis. So clearly these environmental things have to interact with the genetic component. How do those things come together to result in multiple sclerosis? And then finally, could there be a commercial blood test for MS? For some people, the MS diagnosis is quite a journey. There may be multiple MRIs, multiple doctor visits, spinal taps, blood tests. It would be wonderful if we had a blood test that would reliably and accurately help us diagnose MS. We are certainly not there yet. And at this point, your eyes are going to glaze over with this slide. These are the kind of things we have to put up with immunology lectures, and our eyes glaze over. Down at the bottom right-hand corner for you folks is a T cell. And for years and years, we've talked about the importance of T cells in multiple sclerosis, and they are very important. But there's been a lot of interest in the past few years on another cell called the B cell. Up on the top right is a B cell. When B cells grow up in life, they become something called plasma cells. Plasma cells make antibodies. And so when we think of the human immune system, T cells are part of what we call cellular immunity. They help direct cells called macrophages. Macrophages, that's a Latin word for big eater, and they do exactly that. What they should do is go around and eat things like bacteria and viruses and cancer cells. In multiple sclerosis, those big eaters are helping chew up myelin, so they're eating something they shouldn't be eating. And that's largely directed through these T cells. There's another part of our immune system called the humoral immune system. This is the part of the immune system that isn't so much cellular directed, it's directed by antibodies, chemicals produced by the the plasma cells. There's now, again, quite a bit of interest in shifting away from just focusing on the T cells in MS and looking at the B cells and looking at treatments that work through those. So what are these treatments? Well, we have a drug right now called rituximab. Rituximab is off-label. It is not FDA approved for multiple sclerosis. It is used in MS. The story of rituximab is that it was designed to treat non-Hodgkin's lymphoma. In non-Hodgkin's lymphoma, those B cells are actually growing out of control. So non-Hodgkin's lymphoma is a cancer of B cells. And traditionally it was treated with chemotherapy. What researchers discovered, if you look on the surface of that B cell down in the corner, there's a little thing that says CD20. CD20 is a receptor on B cells. When it grows up to become a plasma cell, that CD20 receptor goes away. What researchers discovered is that CD20 receptor is almost like an on-off switch. If you make an antibody that goes in and binds to that CD20 receptor, you take that B cell out of the circulation. And it's very specific. You're not affecting the rest of the immune system. It's not a chemotherapy. Well, once researchers showed that that was a great treatment for non-Hodgkin's lymphoma, neurologists and rheumatologists got very interested because we knew at that point that B cells play a role in MS, in rheumatoid arthritis, in lupus, lots of autoimmune conditions. So people started looking at rituximab to treat some of these autoimmune diseases. The studies of rituximab in multiple sclerosis have looked really good. So why isn't rituximab FDA approved for MS? Because they came up with the second drug, ocrelizumab. Same company, Genentech, tweaked the molecule a little bit, made the rituximab look more like a human antibody and came up with ocrelizumab. That stopped the research on rituximab and shifted everything towards ocrelizumab. Ocrelizumab is slated for FDA approval on December 28th of this year. It will be the first FDA-approved treatment for primary progressive MS. It will also be approved for relapsing remitting MS. So we've got that right around the corner. People are looking at other types of B cell therapies. There's a treatment in testing right now called ofatumumab. Both rituximab and ocrelizumab are twice-a-year IV treatments. The ofatumumab would be a once-monthly subcutaneous injection. So kind of in the eye of the beholder, is that more or less convenient than a twice-a-year IV? At the end of the day, again, we always welcome more treatment options. And if that other slide made your head spin, this one will really make your head spin. This is to sort of give you a little bit of overview on one of the drugs we have available right now. That's fingolimod or Gilenya. Gilenya was kind of a novel treatment when it came out in that it worked on something called sphingosine 1-phosphate receptors. When you think about lymphocytes, T cells in the human immune system, as they're going through lymph nodes, they go from what we call naive, they haven't learned what they want to be in life, to having a job. And their job may be to go out and attack certain things in the environment. And a lot of that decision about what they're going to be happens in the lymph nodes. So what was discovered is that for those mature lymphocytes to get out of the lymph nodes, that's in part through a process involving sphingosine 1-phosphate and sphingosine 1-phosphate receptors. And so fingolimod is a drug that by modulating those receptors, it doesn't let the lymphocytes get out of the lymph node. So it's not killing the lymphocytes, it's just locking some of them up and not letting them get out and do their thing. One of the challenges with fingolimod or Gilenya is that there's not just one type of the sphingosine 1-phosphate receptor. There are actually 5 different types out there, and fingolimod is not specific to just the one we want it to work on. It works on at least 4 of those different types of receptors. One of those receptors that fingolimod or Gilenya works on is actually in cardiac muscle. So if any of you are familiar with Gilenya or you're on the drug, you know that you had to do your first dose with what we call first dose observation. You have to be monitored for your blood pressure and your EKG. This is frequently done in a cardiologist's office. And that's because fingolimod is not just working on those lymph node sites, it's also working in the heart itself. So as we go forward, there are some of the drugs that you see on either end of that top, other mod drugs, are hopefully going to be more specific to working on just the receptors in the lymph nodes, not working on the cardiac areas, and then having a better side effect profile. So that is a whole nother line of research that hopefully will yield better and safer treatment options. There is a therapy that is sort of like, it's an anti-inflammatory drug that looks exciting called Abudilast. This is being tested in secondary and primary progressive MS. One of these trials just wrapped up. We're waiting for the data to see if it was positive. What we know is that the trials in relapsing remitting MS look good. So hopefully it's an oral therapy. It seems to have a good safety profile. We're just waiting to see if it looks like it's a keeper for primary and secondary progressive MS. This is one, when we think about customized therapies to the individual, we don't have the final answer on this, but it's something that we at Shepherd were excited about because we've been part of the research from early on. Originally, this treatment was called Tavoxen. They changed the name to Tiselna. This was developed by researchers at Baylor University, who then set up a company called Opexa Pharmaceuticals and are actually working with this. This would literally be a vaccine for your multiple sclerosis. And what this is showing is that on the top left, the person with MS is having their blood drawn. And what they're going to do with this blood sample is in the laboratory, they're going to isolate MRTCs, myelin reactive T cells. They're trying to find the bad T cells that are causing the problem. Once they have those myelin reactive T cells, they're going to, and let's see if I can get my pointer to work here, they're going to clone them. They're going to make a whole bunch of them. And once they're cloned, they're going to attenuate them. They're going to weaken them. And it sounds kind of scary, but what they're doing is actually irradiating them. They're not killing them, they're just trying to stun them. And then they're going to give that sort of injection subcutaneously back to the person with MS. So you're injecting weakened bad T cells back into the person who donated them. What's going to happen then is your immune system is going to recognize those myelin reactive T cells as weakened, and you're going to make an immune response with something called CD8 cells to those bad T cells. So you can see up here you've got some of the, so you've got this, and then we go to that. So your own immune system is going to kill those myelin reactive T cells. You have just taught your immune system to take care of the problem itself by vaccinating yourself with the bad T cells. Periodically, this person then would go back and have a blood sample done to see if the types of myelin reactive T cells are the same. There is a concept in multiple sclerosis of something called epitope spread, that the types of myelin reactive T cells you have at one time, it may change a little bit over years, and so it may change to something that's different, and at that point you would just make a new vaccine for the person and start the process all over again. From the receiving end, if you're the person getting this vaccination, it's pretty easy stuff. You give a blood sample, you wait about a week, they've made your vaccine, you come back in, you get a subcutaneous injection. Where all the hard work is at with this treatment is actually in the laboratory with this. Trials have been completed in relapsing remitting MS. They recently wrapped up or are wrapping up in secondary progressive MS. Hopefully this is going to be something that works out. Some of the challenges that we've seen so far, I'll go back a slide here, is when you're looking at this step here, isolating the myelin reactive T cells, you'll see that there's this line here that says screen fail, inactive or inadequate myelin reactive T cells. Some people just don't have adequate numbers of those myelin reactive T cells to actually make the vaccine from. Maybe in the future, as technology gets better, you can do the cloning with fewer T cells. But at least in the secondary progressive trial, what we found is that about 50% of our patients did not have the right number of cells to allow this technology to move forwards. But again, hopefully we'll know something sooner. That would be a great step forwards in terms of a truly customized therapy to the individual. JC virus vaccination. Why would we care about vaccinating someone for JC virus? Several of our treatments currently available in multiple sclerosis have been associated with progressive multifocal leukoencephalopathy. PML is the brain infection caused by JC virus. 23% of people with multiple sclerosis who have contracted PML have died from it. Of those individuals who did not die from it, some of those people have been very, very seriously and permanently affected by that brain infection. So it's something that's very significant. Treatments that have been associated with PML are Tysabri, Gilenya, Tecfidera, and there have been 10 cases globally with Rituxan. What if we could vaccinate someone for JC virus, or if we had a perfect treatment for PML such that it wouldn't be such a scary thing if the person developed it? Both of these avenues are being pursued. One of the ways that they're attacking this problem is by actually looking at individuals who have contracted PML and have survived it and have done very well. Interestingly, while there are people who actually die or are severely affected by a PML, there are individuals who have almost no symptoms whatsoever. There was a case recently with Gilenya where a person was diagnosed with PML who, based upon their MRI of the brain, they had no symptoms from it whatsoever, but it was laboratory proven PML, and fortunately they did very well. Why does that person do so well and someone else dies from the infection? They're now looking at the antibodies in people who survive PML to see if we can actually tap into that as either a vaccination or treatment for JC virus. It'd be nice to be able to take that scary side effect of PML off the table when people are making their treatment decisions where there could be some risk of the infection. HSCT, hematopoietic stem cell transplant. How many people have heard of this? So a handful. It's something that has gotten an awful lot of attention here recently. One of the reasons that this treatment has gotten quite a bit of attention is that three research groups are working on this, and they all released some of their updated data at the same time. So probably the group that got the most attention was the Canadian group, Dr. Friedman out of Ottawa, but there's a trial called HALT MS with sites in both the US and the UK. Dr. Burt in Chicago has been very active in this research, sites in Seattle. So this is something that is a global initiative. So what is it? Hematopoietic stem cells. These are immature cells in your bone marrow that have the potential to become the rest of your immune system. So this hematopoietic stem cell therapy really shouldn't be thought of as a direct neural repair. It really should be thought of as a reboot of your immune system. If MS is an autoimmune disease, so your immune system is picking on something that it shouldn't be picking on, what if we just gave you a new immune system? That's the purpose of HSCT. So what they're going to do with HSCT is first a conditioning regimen. They're going to try to get your bone marrow to start making more of these immature hematopoietic stem cells. And there are a lot of differences from one research site to the next in how you do that. This is a safe thing to do. There's not a lot of risk associated with it. And again, what they're trying to do is get your bone marrow to crank out more of these cells. Through blood samples, they can actually harvest these cells. You could get the cells from a bone marrow biopsy. That's a lot less fun than having it drawn from the blood. So most of the sites that are doing this sort of procedure are taking these hematopoietic stem cells from a blood sample. So you're going to take these cells and you're going to set them aside and freeze them and save them. The next step is immune ablation. This is where there's tremendous variation from center to center. There are sites that believe to truly give you a new immune system that we need to wipe everything out. The Canadian site, for instance, and I believe they're probably correct, believes that if you really want to reboot the immune system, you've got to shut down the immune system that's in the periphery outside of the brain and spinal cord, and also try to get any of the bad cells that are in the brain and spinal cord itself. A lot of chemotherapeutic agents that they use for immune ablation don't cross into the brain and spinal cord very well, so you may have to use very aggressive doses of these drugs to really get into the central nervous system. And that's where the risk comes in. There are other sites who are doing less aggressive forms of this treatment, but at the end of the day, the idea is to wipe out as much of your immune system as you can so that you're starting with a blank slate. Then you're going to intravenously give people back those immature hematopoietic stem cells that have been frozen and saved, and tell your immune system, let's start all over again. You got it wrong the first time. You shouldn't be picking on myelin in the brain and spinal cord. Let's do this over again. So you're going to reboot an immune system. These are your cells. This is different than, say, someone with cancer that has a bone marrow transplant where they have a donor maybe from a relative or even a matched stranger. Those individuals who have that sort of bone marrow transplant, those are not their cells. And even if it's a brother or a sister, they're still different enough that that person is probably going to be on some sort of mild immune suppressant for the rest of their life to prevent their body, what is left of their immune system, from rejecting that transplant or the transplant attacking what's left of their immune system. So there's what we call host versus graft and graft versus host disease. People who have regular bone marrow transplants have to deal with that. Individuals with MS who are undergoing this procedure because they're your cells, they're autologous meaning they came from your body, you can't reject them. But there is a period of time after you get those cells back where you have no immune system. You're growing a new one. And so typically after about a month, you're gonna have new cells that are grown, healthy cells. Even when the numbers of those cells are getting up to normal levels, that doesn't mean that your immune system is functioning normally. So we can look at cells in terms of their number, but we also have to think about these immune cells in terms of their function. So it may be months until the person's immune system is really functioning normally. So what do we know about this so far? Well, we know that there are different protocols, and researchers are trying to find out what is the most effective way of doing this. This second bullet point cannot be emphasized enough. This appears to be a treatment that is very specific for certain individuals. It doesn't benefit everybody. The perfect individual for HSCT really is someone with an aggressive inflammatory form of MS, meaning you've got lots of relapses, you've got lots of active inflammation on brain or spine MRI, or both at the same time. When the media talked about, especially about the Canadian experience with HSCT, one of the things that bothered a lot of us in the MS world is they said cure, and they said we are reversing disability. If I'm a person in a power wheelchair and I've been in that chair for 10 years and I see that you've got a cure and you're reversing disability, you've got my attention now. The problem is the people who had reversed disability were mainly people who had very short-term disability. So they had not been in a power wheelchair for 10 or 15 years. They had very aggressive MS and they had recently become disabled. So that really is the ideal person as research stands right now for this procedure. Again, it appears to be much less effective in people with long-term disability. There are multiple sites that are doing this sort of research. To make life a little more interesting, there are for-profit sites around the globe that are not participating in research, they're just doing it. We have an individual who was on Fox 5 News who was pretty desperate with his MS. He went to Mexico and had the procedure done. He's doing well. It has not reversed his disability, but he's stable. We have another individual who is looking at going to Moscow. It's a tough balancing act because on one hand we get that, you know, if your MS is progressing rapidly and if what we have to offer in the toolbox for FDA-approved drugs is not controlling your MS, I think it's normal human behavior to start looking at other options. On the other hand, it's not like we can pull up a lot of research from the site in Mexico or the site in Moscow and say, these are their results. It's very anecdotal. You can talk to people who've been there and they can relay their experience, but again, we can't say, well, of 1,000 people at this site or at that site that had this procedure, these were the complications and these were the successes. So it's a little bit of every man for himself in terms of looking at the risk and benefit ratio. This was one of our recent misses when we talked about things that don't go past phase 2 research. This is one that we were really excited about, anti-LINGO or opicinumab. Again, a lot of these MAB drugs, monoclonal antibodies. This is a result of research that showed in the human body that there is a population of oligodendrocytes, cells that make myelin, that are sitting in a savings account, not being used. And so the question that researchers had is, well, can't we use them? Can't we take those out of our savings account and have them start making myelin again? And they discovered one of the molecules that keeps these oligodendrocytes locked up in that non-usable state is something called no-go, perfectly named. So it tells those oligodendrocytes, no-go, you got to stay right there. Well, of no-go, there's a little piece of it called LINGO. So researchers developed an antibody to LINGO, anti-LINGO. So you're inhibiting the inhibitor of the oligodendrocytes, letting them come out of storage and start repairing myelin. There was some early positive news on this, and it looked like it might be something that would work out. The recent phase 2 trials didn't look so positive, so we're back to the drawing board. Don't know if that's going to go any further. Hopefully it will. Again, anything we can do in neural repair is very welcome. So another type of stem cell that people are very interested in is a true neural repair stem cell. This is a strategy that we hope will yield breakthroughs in terms of reversing disability. These are mesenchymal stem cells. These are more mature adult stem cells, but they still have the potential to become a lot of different types of cells. And you can get these really easily. Where most researchers are getting these from is from fat, from adipose tissue. So really easy to get it. You can do these from umbilical cord blood, from bone marrow, from actually the inner part of your teeth, the dental pulp, from thymus and from placenta. And there are, again, these cells have a lot of potential to potentially repair. I would reference you to some of the research that's being done at Cleveland Clinic. If you Google Cleveland Clinic, mesenchymal stem cells in multiple sclerosis, they've put a lot of their information out there about these successes they're having. So how would these cells actually repair? Well, there's one thought that maybe they actually become healthy brain and spinal cord tissue, like oligodendrocytes. Maybe these cells morph into an oligodendrocyte and start producing myelin. I think that's possible, but I think the second bullet is actually probably more likely, that these cells are actually producing things that might generate repair. One of the things that the Cleveland Clinic is working on is in the animal model, they took these mesenchymal stem cells and they cultured them in a petri dish. And then rather than transplanting the cells themselves into a test animal, they just took the liquid from the culture and they gave that to the test animals with EAE. And what they found is they generated repair. So it looks like it wasn't the cells themselves, but it was something the cells were making. And so there has been some research looking at a chemical called hepatocyte growth factor that looks like it might be one of these things that these cells are making that's generating the repair. These can be given intravenously, they can be given directly into the spinal fluid. In other neurological conditions, there's been interest in maybe putting them into the brain directly. That's not so appealing in multiple sclerosis because in MS, we may be dealing with multiple lesions or lesions in the spinal cord. So the idea of giving them intravenously is much more appealing. And we are going to wrap up with the weird tonight. So human Helminth therapy. Anybody have any idea what a Helminth is? These are worms. So Helminths are parasitic worms. So they're roundworms, hookworms, tapeworms. The idea of Helminth therapy is treating human autoimmune disease with a parasitic worm. Why in the world would we want to do that to somebody? So here's a map of where helminths, these parasitic worms, are more common. I'm going to show you first the multiple sclerosis map. So the MS map, red is more common. So kind of stamp that into your brain. So MS is much more common. North America, Canada, Northern Europe, across Northern Asia. You've got the tip of Australia down there where it's more common. Next is a map of where these worms are more common. You see anything kind of interesting there? It's almost like the exact opposite of one another. Where MS is, the worms aren't. Where the worms are, MS isn't. Coincidence? Maybe. But what we know immunologically is, so when we think about what's going on in multiple sclerosis, this is again going back to the T cells. These immature T cells have the potential to go down a couple of different pathways, and this is a little bit simplistic, but it still holds true. Th1 T cells are inflammatory guys. Th2 cells tend to be more regulatory. Along with Th1, there's also one called Th17 that seems to track along with it. So if you think things should be kind of a balance, we should have kind of a balance between Th1 and Th2 on your seesaw or your teeter-totter. In multiple sclerosis, you live here. Too much Th1, not enough Th2. So we'd like to try to find a way of putting that back in balance. What these parasitic infections tend to do is they tend to be combated by the Th2 cells. So what if we could drive your immune system towards a more Th2 state and balance things by giving you a parasitic worm? Well, we'd rather you not have tapeworms or hookworms or roundworms, but what if we could fool your immune system? What if we could make it think it had that? So what they're doing is using inactivated eggs from these worms, giving it to people, making your immune system say, whoa, I've got a parasitic infection here. I better ramp up this Th2 response, put things back in balance, but not actually give you the full-blown infection. This is being researched. There's a site in South America. University of Wisconsin was doing this. Some interesting stuff came out a while back, one of our European MS meetings, where they looked at some individuals who had MS, who had very active tapeworm, real active tapeworm infections. And their MS was kind of doing okay. And what these European doctors reported is that when they had treatments to kill their tapeworms, they got rid of the tapeworms, their MS got worse. So again, it's one more piece of evidence that there's something going on here. This may tie in to this bigger concept of the hygiene hypothesis in multiple sclerosis, that we may be living a little too cleanly, that our immune system was designed to do something. It was designed to protect us from bad things in the environment, bacteria and parasites and whatnot. And maybe if our immune system is not kept busy, maybe if we're using antibacterial soap and everything's super hygienic, maybe if you have the right genetics, you're more prone to developing an autoimmune disease. If you look at industrialized nations, and if you say go to Northern Europe and you look at a neighborhood where racially everything's pretty much the same, you've got mainly people of Northern European descent, and the only difference in these neighborhoods is income. So you have maybe a lower income neighborhood and a higher income neighborhood. Traditionally, we think MS will be more common in the higher income neighborhood. And one of the questions that has come up, is it because in the higher income neighborhood, the kids are not as exposed to their environment? Maybe they're not in kindergarten or preschool until they're 5 or 6, or maybe in the lower income neighborhood, these kids are out doing stuff and playing in the dirt a little at an earlier age, or they're in preschool at an earlier age and exposed to more. So again, this concept of using parasites to treat MS, not crazy. We don't know where it's going to shake out at, but I think it represents somewhat of a movement to try to also look at things to take advantage of the natural human immune response in managing MS. And I think that's the last one I have, slide. Yep. Thank you guys very much. the